So I think first it's important to talk about definitions. And there are definitions of steroid refractoriness or steroid resistance. And so those typically are related to the timing. So individuals who progress while on steroid therapy after 3 or more days, individuals who fail to improve after 5 to 7 days of steroids, or patients who don't have a complete response after, well, it says here 28 days on this slide, but most of us use a shorter time interval, would be considered steroid refractory. And then, as Usama mentioned before, there is this scenario of steroid dependence, during which you can obtain a clinical response, but you're unable to taper the steroids off completely. And so there are several variations of these definitions, but on this slide here, we have the standard EBMT, NIH, and CIBMTR definitions of steroid responsiveness. And these are the steroid definitions that most of us use in the context of clinical trials, and having this standard set of response criteria makes it easy for us to enroll patients in a uniform manner across studies. There are lots of agents that we use in clinical trials and outside of clinical trials. The slide here demonstrates or lists really a laundry list of agents that have been and are currently considered standard of care in this scenario. And I would emphasize more than anything that the most important agent on this slide is called the clinical trial. Because particularly in steroid refractory disease where outcomes are poor, clinical trials still are our mainstay of therapy. I am going to talk about one agent in particular, and the reason to single out Ruxolitinib in this scenario is because Ruxolitinib was recently approved as a therapeutic for steroid refractory acute graft-versus-host disease. It was approved on the basis of the single-arm open-label phase 2 REACH-1 study. But more recently, the REACH-2 study was recently published in the New England Journal by Dr. Zeisser and colleagues. REACH-2 was a randomized phase 3 trial, and slightly over 300 patients were randomized in this study to receive either Ruxolitinib or best available care. And in this trial, there were 9 regimens that were considered acceptable for investigators to use for patients who were not randomized to the Ruxolitinib arm. The primary endpoint of this study was overall response 28 days after starting the second-line therapy. And this graphic demonstrates the significant improvement in overall response rate to slightly over 60% in the Ruxolitinib arm to a comparison of slightly under 40% in the control arm. And again, large sample sizes, very significant p-value, both statistically significant, but also clinically very significant, I would say, with an increase in more than 20% response rate at day 28. The secondary endpoints of this trial looked at the durability of response at day 56. Again, here we see an increase in the durability, nearly a doubling, in fact, of the durability from 21.9% to 39.6%, comparing the control and the Ruxolitinib arms. Beyond day 56, the rate of losing response towards 6 months was also much lower. It was only 10% in the Ruxolitinib arm. So this, in fact, was more supporting evidence. And finally, the Kaplan curves here show failure-free survival with a very nice, clean increase in the Ruxolitinib arm compared to the control. The investigators showed that, as one would have predicted, there was a significant rate of cytopenias in this trial. Nearly a third of patients had either thrombocytopenia or significant anemia. But very importantly, there was not an increased rate of infections. And it stands to be said that infections are a major cause of morbidity and mortality for patients with steroid refractory acute graft versus host disease.